Hello, everyone. My name is Arya Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on expanding rural access, key insights from implementing telehealth access points across Oklahoma. And today's session is hosted by the Heartland Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just a little bit of background on the consortium. Located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started today. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat for communicating issues with technology or communication access issues. Please refrain using chat to ask questions or make comments. Please note that closed captioning is available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at www.telehealthresourcecenter.org. With that, I will pass it over to Molly Brown, Director for the Heartland Telehealth Resource Center.
Thank you, Arya. As Arya mentioned, I am the director of the Heartland Telehealth Resource Center. We provide support to Kansas, Missouri, and Oklahoma in partnership with the Missouri Telehealth Network and the Oklahoma State University Center for Health Sciences. Today, we are showcasing one of our regional experts as we explore key insights and practical lessons learned from the implementation of 5 telehealth access points across Oklahoma. This session provides useful takeaways to improve your own telehealth services and better serve patients and clients. So now I'd like to introduce our speaker. Samuel Karns is a passionate advocate for telehealth, rural health, and library services focusing on underserved communities. Currently, he serves as a consultant with Oklahoma Complete Health, facilitating collaboration among rural clinicians and leading initiatives to expand telehealth and rural healthcare. With prior experience at the Oklahoma Broadband Office, he contributed to the state's digital equity plan, initial proposals, and 5-year action plan through extensive outreach and data collection. Samuel also provided consulting services at the Oklahoma Department of Libraries, supporting 28 municipal libraries and 2 multi-county systems, and worked with the Department of Corrections to enhance library access for the incarcerated. Now I will turn it over to Sam.
Awesome, thank you. My name is Sam Karns, rural and telehealth specialist here with Oklahoma Complete Health. Just want to say thank you to Molly and the Heartland Telehealth Resource Center and the National Consortium of Telehealth Resource Centers for the opportunity to come speak. And thank you all for attending this. We're getting to dig into a couple of things that I love the most, which is library services and rural health, and kind of the intersection of both. Just to begin, so I work for Oklahoma Complete Health. We're a subsidiary of Centene, which is one of the nation's largest commercial healthcare programs. Essentially, we are in all 50 states, and there's a big focus at our organization on the individual and whole health, and then also active local involvement, which you wouldn't think from a large multi-state conglomerate like us, but we really try to have a strong local focus in the communities. We think that's the best way to get out and meet the members is, having something that they're familiar with and comfortable with. So most of our employees that serve in each of the states are going to be from those states. And I myself am from Oklahoma as well. I grew up in rural Oklahoma, out in Watonga, a little bit, it's like an hour, 2 hours out west. So I'm really intimately aware of all of the issues there in the rural US. Just a snapshot of our members. We've got 28.5 million members. here in Oklahoma, we have a little bit over 200,000 Medicaid members that just came online. Um, we're one of three providers there. The other two being Humana and Aetna. Um, One of the things I like to highlight, though, is that we're the nation's leader in managed care for the foster care population. And in Oklahoma, we're a sole managed care partner through our specialty contract. And when we start talking about um, services to rural communities and having a focus on whole health and the individual, it's usually in the context of social determinants of health like this. There's only 50% that can be traced back, or 50% can be traced back to your zip code. And so a lot of these issues are going to be compounded once we get into the rural communities as well. When it comes to education, it's lower educational attainment, um, lower average job pay. There's going to be significant gaps in care. Some members are having to drive, an average of 30 minutes, but we have quite a few members who have to drive upwards of an hour or more just for basic care and most especially specialty care. In the southeast region of the state, we just had one of the only um, OBs actually close. And so some of our members are left kind of with the option, if you want to stay in state, you're going to be driving 2 hours to get service, or you can either drive maybe an hour to Arkansas or 45 minutes to an hour into Texas to get service. And that's just one example that depending on where you're at in the state, there's going to be significant gaps in care. And so one way that I like to look at it, obviously, so that when it comes to access, these barriers kind of overlap to create varying degrees of access, or lack thereof. Some people may not have transportation, but if they have connectivity, we can get them telehealth. They may not have connectivity, but if they have transportation, well, we can pay for a ride to get to whatever a local provider is. And some don't have any of those options. They don't have connectivity, they have no transportation, have no physical option. And I think that's where something like telehealth booths and those other solutions as well come in, some mobile clinics. Just trying to get out to meet the member is very difficult in some of these areas. So it's coming up with strategies about how you can get into their communities and I guess fit into their routine, their day-to-day routine, so that healthcare becomes easy for them. As easy as it is for someone who lives in the city who has access all the time, who may only live 10 minutes away from their doctor or less. But this is how I like to picture it, is these overlapping barriers. And when we come in, we can either try to remove these barriers, and that creates access naturally, or we can come in with targeted solutions that essentially kind of bypass some of these. The one thing I do want to highlight is local knowledge. All of this is located, within local knowledge. And this is something that the more you get into rural communities, the more you see is that you may think transportation is an issue, but then when you get into a community, you realize that the community action agency may have a transportation route that you didn't know about. Or a local tribe may have some benefits for clothing that you may not know about, different things like that. So some of this is all housed within local knowledge and affected by it. So how this looks in Oklahoma, I kind of want to highlight. So this state of Oklahoma health inequity map, as you can see, the dark areas are high risk. Pretty much outside of our major city centers, Tulsa and Oklahoma, you're going to have some high risk areas. And these are composite scores of life expectancy, opportunity index. And so they'll include healthcare and, the job opportunities, different things like that. Um, but I like to show that it really highlights that once you're outside of those city centers, there there's just significant caregivers in these areas. Um, and also some of these instances when we're talking about the high risk areas, they may be 10 to 15 years lower life expectancy. I just looked it up, and so we've got some counties here in Oklahoma that have a life expectancy of 69 years old. And there's some counties in the US that are pushing 90. So it's significant differences here. And also to highlight, the average drive time in these areas is also going to be 34 minutes to the nearest hospital. And again, that may just be a local FQHC or something. It may not be like a high risk hospital, not able to serve everything. You may still have to get Metaflight to the city so that they can take care of you there. But this is something that I think telehealth has a great opportunity, steps in and can keep members there and without so okay, there we go. I lost video for a second. We're able to keep with telehealth, we're able to keep members in the local areas and essentially bring the specialists to them. Another map that kind of tells the same story is this the connectivity map, essentially. This is going to show where members have internet and where they don't. And ideally, you want to be in the green. That's going to be 100/20. That's going to be reliable enough to have video conferencing calls with a provider. You can have back and forth information exchanges, no problem. Anything less than that, it gets iffy. You can still do it, but it's not reliable. As you can see, it's kind of the same areas outside of the city centers. We still have some significant gaps in connectivity. I will say this is one of the areas that we're most poised to solve right now. There's a lot of funding coming through from the federal government. A lot of the broadband offices that have been set up around the country doing great work. And they're setting up these BEAD programs, CPF, digital equity programs that will help close these gaps. And they've already started rolling out some project funds. And so we're starting to see this change kind of real time right now. And hopefully over the next 5 to 10 years, as these projects all roll out, this will become a problem of the past, and we can forget about that portion, that being a barrier anymore. And then now kind of to the crux of the issue too, if you'll remember from those previous two maps, where those high risk areas were located, the low connectivity also line up pretty nicely, and if nicely is the right word, with these tribal jurisdictions. And, the tribes have been underserved for years. And you're starting to see that in these access maps, essentially. But it creates another layer to work with in the sense that there's a lot of tribal knowledge and of resources and just different ways, different processes that can be both beneficial and kind of a hindrance in the sense that it's a new process that you have to learn. And then also try to figure out how to work with them directly. And this is something I firmly believe that if you work with the tribes and you get them access most of them, and I say most, all of them serve all of the people, all of the residents who live in those counties. Um, Maybe not all services, but they're not going to turn you away from their hospital. If they have an internet provider, they're going to service you if you're in their service area. Um, and so, insofar as we can partner with tribes, not only are they, trusted members of these communities here, but since they've been underserved for so long, it's a good way to um, kind of fill these service gaps that have been around. Um, and one of the things that we've done, so these telehealth access points, kind of what we're here to talk about, was a good way that we could get out into these communities. It was a way to set up partnerships with them. And what they are is essentially just a booth or a room that we have made more private. We've pre-positioned equipment inside of them, so diagnostic equipment. And then we have, we've set up cleaning procedures. Since these are all located in libraries, they're going to have what we call digital navigator, somebody who's there and can help people, either set it up or they can sit through with a patient and help them with, use any of the diagnostic equipment as well. Really think that's one of the a vital part of having these is without those digital navigators, then you're having to deal with a lot of digital literacy issues. But this was a way that we could go and we could physically put something in these communities. And not only were they great, it was a way for members to go ahead and use these anytime they wanted. But, what I think is the biggest selling point for them was opportunity for partnerships with local providers. It was also a way that we could get private spaces. None of these communities had any private spaces. And that was becoming a significant issue, especially during COVID with, everyone switching to Zoom. Nobody had any place to meet. But this was a way that we could get a private space out there immediately. And then also, it being clean and private, it's accessible. It just created these, it's a true access point in a sense in these communities that didn't have them at all. And so these are the 5 that we placed. So we've got Broken Bow, Hinton, Okemah, Tulsa, and Atoka were the 5 that we placed. We went in with a partnership with Oklahoma State University, and then Oklahoma Department of Libraries as well. Each one funding different portions of it, and then Oklahoma Complete Health kind of coming in and providing some just kind of the medical expertise part for the partnerships. And we're currently in the phase right now, so we've got these rolled out into all 5 locations. They've been live for about 4 months, and we're in the data collection phase. And so what we did there is we partnered with, again, Oklahoma State University has a really robust data collection, surveying team, and they created an IRB approved survey and have rolled it out to their locations. And so now we're waiting to collect data. So when we're rolling these out, one of the things I wanted to highlight for everyone is digital navigators were a very important part of this. And so when we were scoping out locations, that was kind of the question, who was going to be our digital navigator? And so a lot of our sites were chosen for, in a sense, like digital competencies. Most libraries are going to have some level of that. They all help people day in and day out with accessing stuff online or helping people with resumes, creating accounts online. the list is endless of the things that they help with. But I just wanted to make sure that these people were a little more comfortable with it, and so that they could actually help someone in a physician's visit. But these models are already out there, exist. If you're trying to roll this out, there's multiple toolkits, job descriptions, trainings. Um, there's everything that you can need for these. And if you need any of it, either reach out to your telehealth resource centers. You can reach out to me as well, and we can get it sent over to you. Uh, but just thinking about that's when rolling it out, make sure to think about who's going to be your digital navigators, how are they going to be trained. Um, Another big consideration that we wanted was standardization. We didn't want these, while we wanted the libraries to help with these, we didn't want it to dominate um, their workflow. So one of the ways we did this was kind of automating the cleaning process to an extent. So they're all going to have HEPA filters in them that passively clean the air. They also have UVC lighting in it that will disinfect between uses. So essentially, someone leaves, button you can click, turns on the UVC. Between that and the HEPA filters, it gets the surfaces and the air clean. If you have equipment that needs to be cleaned, or just if you want to do a deeper cleaning with something, I always recommend. So we bought electrostatic sprayers. This just kind of ionizes the cleaning solution and makes it clean better to surfaces. And it's also very fun to use. So highly recommend. You just get to you walk in, kind of blast the room with it. But as I said there, it's much faster than trying a traditional wipe down. It's 20 seconds to clean a wheelchair versus 84 seconds. And this is something that, anytime someone has to clean a surface, I always recommend these. It just makes it so much faster. Another question that we get a lot, another focus when we're rolling it out, was privacy, obviously. So all of these are soundproof. Our individual booths that we rolled out came soundproof from the manufacturer. And they're truly soundproof in the sense that you can't hear anyone talking in them. You'd have to hear someone yelling. And even then it's pretty faint. But just to be sure, we also include a white noise machine, just to mask any other sounds, make sure no one can hear anything. This is a big deal in rural communities. I always say, like, everyone's business is everyone's business there. And so anytime that we can encourage privacy and making more soundproof, that's what we want to push it towards. And I also want to highlight too that privacy is a big concern for libraries across the board. And so that also made them another natural partner in this, is that we don't have to worry about them talking about visits or something that they may have run into through our training. They understand that a HIPAA exists, and then also they deal with people's private books and checkouts, and they help people on the internet day in and day out. It's just something this is very much in their wheelhouse. When it comes to computers, it's another question we get. All the computers are set up with CIPA compliant firewalls. That's a requirement for libraries. And most of them are going to have some sort of firewall already on their public computers. And they also have to have them on staff computers as well. So it's pretty easy for us to get that put on. They're also set up to wipe all data between uses. So I think most of the libraries are going to use something like deep freeze. There are some though, so Google Admin's another great one that you can set it up and just wipe it, choose when it wipes, either at the end of the day, between uses. There's a lot of those. If you need help, we can reach out again. We'll get that taken care of. So just some examples of what these look like. So the Benson Media Center, this is Okema. This is a church remodeled into a media center. They added a elevator to make it ADA compliant. There's going to be a bunch of computers set up in there. And honestly, I don't know all of the resources they have now. It was just opening up when we were rolling this booth out to it. But, um, you know, we partnered with local providers, county health departments, and then my organization as well. And we've held the health fair there, had a grand opening. Um, and that worked out great. Had a mobile clinic come up and then just kind of showed off the booth as well. Oh, and one of the things I like to highlight too is kind of the growth that came from this was Cliff right there was the director of this at the time, and he did a lot of research for us for partnerships, best practices, and he works with me now. We Oklahoma Complete Health grabbed him up, but I just like to highlight it. Telehealth in these communities that don't have it before, it's more than just providing access; it provides opportunity, and that's something that they all need, that we all need. Another example here is the Southern Oklahoma Library System. So we funded one in Atoka for them, but they had since expanded to 2 other locations, and they're looking for funding for a fourth. They have partnered with Red Cross, FEMA, Small Business Administration for disaster response. They've been using their spaces. So Atoka was just recently hit by a really bad tornado. It took a lot of damage. Luckily, the library was one of the few things standing in that area, that section. It was about 1 block away from completely being wiped out. But because that was still open, we were able to use these spaces, their meeting spaces and these telehealth booths. But they've kind of gone all in the health arena, you could say, I guess. They hold vaccine clinics, they have exercise equipment, they do health literacy programs, all of that. Hinton is another one too that we've just rolled out. And I like to bring this one in just to highlight all of the equipment that we put in all these. These are very easy to use self-diagnostic equipment so that somebody could go in and do the diagnostic portion of their doctor's visit just with their physician talking them through it. So one of these, so example like Tyto kits or a med wand, something similar is like an all-in-one scope, and you just have these detachable pieces that you take on and off. Really easy to use. Again, your physician could walk you through it. This one is also exciting, and I'll jump back to this, but it's located on the same ground as the public school. So it's a lot of opportunity there to use it for school telehealth partnerships. So some other use cases are, again, school telehealth. People have used them for sensory rooms. I really like to think of it too as like a supplement for mobile clinics. A mobile clinic is going to be very expensive. So Oklahoma just bought 2 medium-sized semis that they repurposed as mobile units. They've got a couple rooms in them, a lobby, some diagnostic equipment. And, for 2 of them, it was a little over $1 million. And I just think about like, for $1 million, I could put one of these in almost every town in Oklahoma. So when you're thinking about a rural response plan, I like to include these as like as a supplement, in the sense that if you were to take your mobile clinic that has 1 room and you went to this community, if you stopped at the library and could utilize these spaces, you then have 2 meeting spaces instead of just the 1 from the clinic. The nice thing too is that these aren't, the mobile clinic goes away at the end of the day. You may not see it again till next year. if that. And these things are these stay in the community and can be used for multiple purposes. At least the ones that we implemented are actually movable. They're not, they don't have to be fixed to a certain location. So if we wanted to move it to another school or something like that, that would utilize it more, that's something we could look into. We've got senior centers that are looking at it. Well, as I said before, there's disaster response. It's a great option to have for FEMA. And then vaccination clinics as well. And I just wanted to highlight too, so we partner with Oklahoma University, has a great telehealth program. Just wanted to show this quick video.
When your kids get sick at your school, it can be stressful to know what to do. But thanks to a new partnership with Oklahoma Children's Hospital, OU Health, sick days are about to get a whole lot easier. Oklahoma Children's Hospital's school-based telehealth program brings the expertise of our trusted doctors and nurses to your child's school. Here is how it works. When your child visits the school nurse, the nurse has the option to start a video visit with a doctor at Oklahoma Children's Hospital. To be eligible for a video visit throughout the school year, you will need to submit a signed permission form in advance for your child. Through a secure video connection on a tablet, the doctor at Oklahoma Children's Hospital is able to evaluate your child's symptoms, make diagnosis, and send electronic prescriptions to the pharmacy of your choice if needed. Some common conditions seen during school telehealth visits include sore throats, earaches, cold and flu symptoms, rashes, abrasions, and pink eye. Using a handheld camera, digital otoscope, and a stethoscope, the school nurse can assist the doctor in looking in your child's ears and throat, look at the child's skin or eyes, and listen to their heart and lungs. After the school telehealth visit, the doctor may recommend your child return to class or be picked up from school. If needed, they can help arrange in-person follow-up care. Parents are updated after the visit, or they can choose to join the visit virtually. Visit summaries can be sent to your child's regular doctor, or Oklahoma Children's Hospital can help connect you with a primary care doctor if your child does not have one. To sign your child up for OU Health school-based telehealth program, ask your school nurse for an enrollment packet, which includes forms about your child's health history and consent form. The school-based telehealth program is available to any enrolled student, regardless of insurance coverage status. No out-of-pocket payment is needed. If you have insurance, insurance will cover the cost. But if you do not have insurance, the visit cost will be covered for you. After you complete these forms, you will return them to your school's front office or school nurse.
I'd just like to highlight their program. They do wonderful work. And there's a lot of providers now that are expanding into that area. Just met with Oklahoma State University as well. They've been expanding quite a bit in school telehealth arena. So there's a lot of opportunity for these to support that expansion as well. So some of the challenges to deployment that we're facing, at least right now, is the first one, I think, visibility. Is nobody knows that these are in there, especially just being in 5 very rural locations in Oklahoma. There hasn't been enough talk about using these, but really talk about telehealth in general. Nobody has that reflex right now of, oh, something may be wrong. Let me see what my telehealth, what telehealth resources I have. So can I call in first before driving an hour to an urgent care or wherever it may be? I think this is a tough issue because it's not just the patients that we're trying to educate, it's the providers as well. The providers know their patients best, and are able to send members who may need something like this to it. And if the provider doesn't know about it, it's probably not going to be a suggestion ever. And so patients then, it kind of trickles down in that way. Patients aren't going to use it. It's really hard to get patients to ask to use something like this as well if their provider is not on board with it. So really, it's a big job in educating the field on what's available. What helps with visibility as well, we're finding out is these alternate partnerships, school telehealth. If a booth isn't having very good traffic, just where it's located in the library, but you can bring in a school telehealth program, well, suddenly it's used heavily then at that point. So really being intentional with the program and the partnerships and the planning, just making sure that you have these use cases already lined up at the beginning, and then just following through with those partnerships. And then also another thing is consider advertising these spaces for uses other than doctor's visits or medical uses. Just any private meeting space is going to bring visibility to these. Word of mouth is huge in small communities, and it's just a great way. If somebody goes in and uses it for a Zoom meeting or a job interview, then they can talk about it to family members, and that's just a good way to get the word out. Challenges to tribal, kind of what I've mentioned before. It's there's a lot of what's the way to phrase it? Some of them just have different ways of doing business. And it's just the difference in cultures. And so it's something that you have to really dig into ahead of time and learn and make sure that you're going through the right channels. One of the mistakes I made at the beginning was trying to go too fast with these, with one of the tribes. And really, I think you have to build that relationship first. But when you do, they're amazing partners. And, they have a lot of buy-in when it comes to telehealth because they really want to protect their elders, who are some of the only people who know their language. And so they can really see the value in something like this. It's just making sure you go to the proper channels. And again, another example would be, thinking that you may want, just trying to get approval from one tribe without knowing any of their history, without realizing they may be on a council. And so you would actually have to get the approval of all 3 tribes who were on the council. And that's obviously going to take much longer. It's just a more involved process. I really recommend having a tribal liaison to help you with this and just kind of navigate the processes. Some of the regulatory challenges right now are the uncertainty in the prescription rate waivers, not having great payment parity, other federal regulations, just making providers cautious, and that just makes it harder to partner in a sense. Another issue is the Affordable Connectivity Program, just kind of, I think it wasn't going to get funded, and then it was, and then it wasn't, and then it was, and now it is, I think. But the issue is 300,000 Oklahomans would lose access to internet. That's a problem when it comes to trying to roll out telehealth and make it ubiquitous across the state. And then also the provider compact statuses. Those make it much easier to roll out telehealth programs because we have such enormous issues with the worker shortages kind of across the board, nurses, physicians. Yeah, we need help with all of those positions. And so luckily Oklahoma is one that has embraced these provider compacts. but it's still something you have to work through at the time. And then, in some states, they may not have embraced it as fast. And so it becomes an issue trying to roll out like a nationwide program. And kind of just wanted to tie it all back to, this is just one facet of trying to solve this rural access issue. Ideally, we can go in and knock out some of these barriers like connectivity. But while we're still working, that takes time. And while we're still working on that, we can move in and come up with these targeted solutions to where these issues overlap. And it doesn't create the same level of access, but it does create some access. And that's what we want is, giving people some choice in the matter, I think is always a good thing. And really it's just an opportunity for us to go in and, like I said before, meet them where they're at and try to come up with solutions that fit their needs and their community. And really the local knowledge again ties it all together in the sense that most of these programs can be taken out and put in another state, but it may not work in that iteration. It has to be customized to fit that local community so that there's trust and buy-in. And yeah, and that's just really what I wanted to highlight is that it's just an opportunity for us to build trust, and really to get healthier Oklahomans, healthier people in the sense, the lack of access before is such a huge issue and compounds so much that if we can come in and even fix one issue, one small issue, it may have bigger outcomes, better outcomes later on, and kind of have a cascading effect as well. So with that, are there any questions?
Thank you, Sam, for your time and what a great presentation. I actually did have a couple questions. One of those was, can you talk a little bit more about the digital navigators in terms of training? Did you and your team support that? Was it something that was already in place? Maybe share a little bit about that.
Yeah, so it's gonna be a little different for everyone. In our case, we partnered with individual libraries, but not all of them. 3 of them were municipal libraries, and 2 of them were system libraries. So at least in Oklahoma, the municipals have a lot of the time, and they're really the ones who own the staff, and since that they're responsible for training and things like that. So what we did was provided these materials to them, and then they were responsible with either hiring. We provided funds for them to either train and hire, or hire and train a new person, or to just train and add hours onto an existing employee. And so most of them, I think, actually ended up just doing that. They had a part-timer who they already had in mind. We provided the trainings for them, and then they went in and just basically became full-time employees for the duration of the project.
Okay, thank you. We have a question from one of our participants. I'm going to let them ask. Go ahead, Lula.
Yes. I was just wondering, is there any way that it's right now, and how will
Lula, I'm
the
Sorry, I think
sorry.
you're
clients or
cutting
work with,
out.
with the system there. Can you hear me?
You cut out a little bit. It might be, are you able to put it in our the Q&A option?
Yes.
Okay. And if we don't get to it by the end of the presentation, we'll be sure to answer it offline via email.
Okay.
Were there any other questions? I'll keep an eye out for Lula's question.
I
The
just see
next
a
question
couple
I
on
had,
the Q&A. Oh, sorry.
oh, I'm sorry. Let me see. Oh, there are some. Sorry, I closed it. Are you able to share more resources on the connectivity access or access equity?
Yes, although I'm not quite sure what you're asking about. So are you asking for members who don't have any internet connectivity? Just what some resources for them? And if that's the case, we can definitely get you some resources for that. It's all going to kind of depend on what's available locally. Some states have additional programs that may help out. There's some federal options as well. But one of the things we provide, at least with Centene, is we have a program called Connections Plus that supplements Lifeline. So anyone who doesn't qualify for Lifeline, but we still want to get them a phone with a plan so that we can stay in contact with them, that's something that we just provide. Our care managers can go in and submit that request, and we'll mail it to a member's house within a couple of business days, usually.
The next question is, I represent a combined telehealth, telemedicine technology that would provide greater medical services with the support of a local regional medical provider. What is your recommendation on how to link up with local organizations to trial and demonstrate?
So if you are asking about partnering with someone like a local library that may have one of these booths, I would recommend going through the Department of Libraries. They'll have contacts for all of these locations. Yeah, that would probably be the best way to go about that as well. If you're just looking into if you're looking for a more general partnerships, just wanting to demonstrate it with any local providers, your Office of Rural Health may have some insight into that as well. And it's probably the route that I would go.
We did have, and I know you talked a little bit about cost. Are you able to share maybe what is the actual cost for maybe one of those access points in a library, roughly?
Yeah, so ours and that we have different options in a sense. We went through with TalkBox at the time, and that was after we checked multiple vendors. I tried to design my own at one point, and it was just going to be too expensive going those routes, and it wasn't really going to get us the quality that we wanted as well. We found one who was doing it already, TalkBox, and they already had one of our libraries had already bought one outright, the Lawton Public Library. And they were in talks with TalkBox on how the design and everything like that. But it was at the time about 20,000 for each of those. And that kind of comes with like the soundproofing, UVC lights, HEPA filters, the conduits and the air conditioning system and all of that kind of stuff, the lighting. But there's also, it can be much cheaper as well. We just priced one out so someone has an existing space we can retrofit a space in the same way, and it's significantly cheaper. With all the equipment, it's like $5,000 probably. And that's kind of what I was referring to, was like, if you were to give me $1 million, like I could put one of those in every town for $5,000. That's pretty cheap and doable. And cheap in the sense of, if you're writing grants for these, if you're thinking about it in terms of grant funding, and spending and trying to work it into a rural access plan, it's relatively cheap in that sense.
I have another question. So Charles, would you like to ask?
Recording in progress.
Molly, did you ask me a question just then?
I see your hand is raised. I didn't know if you wanted to
Oh,
ask.
no, you answered my question. Sam answered my question. Thank you.
Okay, perfect. And then one other question in the Q&A was, how can clinicians in other states maybe partner with you or the work that you're doing, if that's something that's available or open?
Yes. And that's something that, again, wasn't a consideration at the time, because working through the compacts and things like that. I would say in that case, if you would reach out to me, yeah, if you could reach out to me, or Oklahoma State University is another one, or Department of Libraries, that's something that we could help facilitate. Trying to think if there's any other, really probably reach out to me would be the best route, and I can be connected with whichever location or with the Department of Libraries.
And I think we will be sending out a follow-up email, or at least the recordings will be available on the National Consortium website, but then also we can provide Sam's contact information if you reach out to us directly. We do have time for this last question. Are there outdoor options?
And we don't really have an outdoor option right now. Most of these are going to be located in a library, and it's like a bookable space. It's enclosed. The outdoor option, I think, becomes, my concern then is thinking about privacy and how we're going to keep it private. Also, at least in Oklahoma, it's just so hot. It would be really uncomfortable. You could use it like twice a year kind of thing. And so that's something I'm open to thinking about. I just haven't really thought through what an outdoor option would look like. But I do think that could be useful as well.
Well, and I'd also think us in the Midwest with our weather that's unpredictable. In Oklahoma, it can be
the
a
rain
little
comes sideways. It could be hard trying to keep the water out of there. Yeah.
Right. So, were there any other questions before we begin adjourning? I don't see any. So thank you, Sam. Aria, I can turn it over to you now.
Thank you, Molly. I'm just going to bring up our closing slides here. Just a reminder that our next webinar will be held on Thursday, October 17th. That will be hosted by the Southeastern Telehealth Resource Center, and it will be on improving specialty access and decreasing hospital transfers with inpatient telehealth services. Registration information is available on the NCTRC events page. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to the Heartland Telehealth Resource Center for hosting today's webinar. And thank you to Samuel Karns for his presentation today. Have a great day, everyone.